Good evening, everyone. To those of us, so those of you who are joining us from India, and good afternoon to those who are joining us from UK. My name is Sonali Kindra, and I'm a general practitioner in England and also a clinical associate within the primary care team in NHS England. This is the fifth in our India UK COVID webinar series. Thank you to all of you who have joined us previously as well. It's an important topic for today. We are covering the mental health and well-being and support for our healthcare workers, those who have been at the front line during the COVID pandemic. It's had an impact on all of us, not just because we've been there experiencing just as our families and friends have gone through the COVID pandemic, but we've been there at the front line sharing the trauma and experiences that our patients have had to go through as well. Really grateful to the entire panel today, where we've got a mix of expertise from UK and India to be able to share their experience. These webinars are, as was described by Rachna last week, are knowledge sharing webinars. We have all been through, in UK, through a second wave, and we are going to be sharing the experiences from UK, as well as learn from our colleagues in India as well, who are doing a stellar job at the front line. I'd request all of you to keep your videos and your audios off and listen in. We won't be able to respond to any individual queries, but please use the chat functionality to raise questions, and we will be able to come to the question and answer session once the presenters have presented their topics. We're going to be covering today about immediate emotional impact, as well as medium and long-term sequelae, and also hear from the task force on Doctors for Doctors, as well as experience from Dr. Mathur about working in an acute COVID ward as a psychiatrist. So without much further ado, I invite now Dr. Ananta Dave to kindly give her experience of working in the UK during this time. Thank you, Ananta.
Thank you, Sonali, and greetings to all, both afternoon and evening, to those in the UK and to my colleagues, friends, families in India. Yeah, I'm Ananta Dave, and I work currently as a medical director and as a consultant psychiatrist in a mental health trust in the UK. But what I'm going to share today over the next few minutes are a combination of my experiences working as part of a system as well, a group of NHS trusts and other organizations coming together. So I hope that what I share, although it is based on UK experience, that there are some general points, some learning and some reflections that will hopefully be of relevance to colleagues in other parts of the world and in India. So next slide, please. So I'm going to cover more about how we can respond as individuals and organizations rather than the specific emotional or mental health presentations or manifestations that we can see. So before I go into what it is that we can do as organizations, or what we did and what worked and what didn't, I think just important to keep in mind that in the early phase of a response to a crisis, or of the proportion that the pandemic has been, the vast majority of presentations are going to be understandable reactions to the sheer scale, the magnitude and the intensity of the experience that people are going through. In this case, health and care workers are going through. So the combination of extreme distress, tearfulness, anxiety, lack of sleep, the fear, the uncertainty, the traumatic images, these are understandable reactions. So it's less about diagnosing people with the condition and more about helping them with the immediate response and what it is they can do. And then afterwards, as we go along, I think looking at it in terms of specific mental health interventions. So I think what matters for most people, so whether you are an individual clinician or any other member working in a health or social care setup, whether it is a small private clinic or a big hospital or a community center, what matters most to people at such times is somebody keeping me in mind? So if you are a manager, if you are responsible for people working around you and under you, then are you doing what you can to keep people in mind and thinking and acknowledging about what they're going through? If you're a clinician or a nurse or any other member of staff yourself, you want to know, does the management care? In simple words, is it bothered? Does it care? Does it realize what I'm going through? Is it aware of the magnitude of the problem? So I think it begins with that simple question. simple aspect of being kept in mind. And I think so. On that basis, whether managers are acknowledging the extent of the crisis and the extent of the impact on staff working with them. So the full extent of it, ranging from having to deal with the pandemic itself, the unusual presentations, the sheer numbers coming through, the number of deaths that staff face, the conditions at work which increase risk of COVID, their anxieties about family members back home, their conflict in making those decisions about, how do they prioritize their family versus work? How do they make sure that scarce resources are used effectively for each patient? So are the managers aware of the extent of the impact on staff? And how is this being communicated with people? So if you're a manager, if you're a leader, how are you communicating with your staff, and how visible are you? I mean, it might be remote visibility through online and the web, but how visible and accessible are you as a leader? So that's what matters in terms of general stuff. And then I think, a big impact on emotional and mental well-being is your physical safety itself. So really important, as much as is possible. I mean, we're aware of the constraints around supplies and the gap between capacity and demand, but as much as possible, taking care of the basics first. So in terms of the hierarchy of needs, the fact whether you're physically safe or not, in terms of your PPE, the social distancing measures, the public health messaging that's going out, and basic requirements like food, hydration, rest. So what facilities are available, or if not, how best are we trying to make these available for staff, or trying to keep that in mind while looking at staffing rotas, duties, taking turns, etc. So really important to get these as right as is possible under the circumstances, given all the constraints of supplies, etc. And in the UK, we talked about the disproportionate impact on certain groups of staff, and the Black, Asian, and minority ethnic, whom I'm going to refer to as BAME staff in short. So they were a high-risk group in terms of the disproportionate impact and the numbers of patients and staff who were affected in terms of severity, deaths, etc. So clearly this put that increased pressure and uncertainty and anxiety in this group of staff. So similarly, in India or any other part of the world, those groups of staff who are at high risk, whether it is due to age or an underlying condition, or any other immunosuppressant factors, we really need to take into account how are we supporting those groups of staff who are at high risk. And the picture on the right shows the various risk assessment tools that were formulated in the UK by various organizations, ranging from NHS providers to the Royal Colleges, including the Royal College of Psychiatrists and Public Health England. So a variety of organizations looked at how can staff be assessed for their level of risk, and how can we then mitigate or reduce that risk as much as possible. Next slide, please. So after we have looked at the COVID risks and physical safety and needs of the staff under our care, we then look at what might help in terms of emotional well-being. So firstly, what I'm covering in the next few minutes now is around the short-term support that organizations can provide. I think later on in the talk, in the webinar, we are going to have a presentation around the long-term impacts. But in the short term, it is about not only about making sure that support is available, but about being flexible. So firstly, acknowledging the level of distress and the moral injury. What do we mean by that? And there's been a lot of talk about it, but it is about the conflict between what you would like to provide as a care provider, as a doctor, as a nurse, and what it is that you're actually able to do on the ground, whether it is enough oxygen, enough ventilators, enough number of beds, getting medicines, on time to people, the number of vaccines available. This is the lack of availability, and the sheer scale and speed of things is at odds with what we have taken an oath to provide and what it is that we would like to do. That causes huge moral distress and conflict. And also about our anxiety around what it is we are doing to our colleagues and family and putting them at risk while we do the work. So the conflict that comes in, the ethical conflict, is really important to acknowledge. And for the vast majority, low-level interventions are likely to suffice. So by that, I mean we don't need specialist psychiatrists or mental health professionals. However, there needs to be a psychological mindedness and a basic awareness of what staff might need in terms of support and emotional support during that time. So only a small proportion may need referral to specialist mental health services. Next slide, please. The vast majority of them can be supported within organizations. So what is it that managers, etc., need to be aware of? Presenteeism, where people are coming into work but not able to give their best. The need for safe spaces where there is responsive, timely, flexible provision of mental health support. Working in teams, reinforcing team support and team building, and making managers psychologically savvy, and avoiding specific debriefing. Next slide, please. Just one slide left. And these are my reflections. The important thing to remember is start early. Whatever support you're providing, start early. Don't wait till everything is perfect. Keep communications open. Keep staff updated with accurate and latest information. Look out for marginalized, isolated groups. And remember that one size doesn't fit all. I think the next slides are about information about the weekly groups that we hold. So I just want to say that this is what trust can do at organizational level. Next slide. And what we provide in terms of weekly drop-in sessions, which is available to all staff in the UK and India, which is a facilitated supportive session. So this is organized by British Indian Psychiatric Association, but there are various other sources of support as well. Thank you.
Thank you so much, Ananta, for sharing that. And I think certainly take-home point for me was to start early. So while we're in, India is going through its second wave of pandemic, and right in the thick of it, it's sometimes hard to take out time for these things, to find those psychological safe spaces, but they're so important to really sow the seeds for to ensure that we don't get medium and long-term sequelae. So thank you for sharing that. And now I'd like to welcome Dr. Supriya Mathur, who is MD Psychiatry in Jaipur and has, as a psychiatrist, had been deployed to an acute COVID ward. And she'll be speaking about her experience in the acute COVID ward, as well as using her skill set to help not just the patients, but also the staff. Thank you, Supriya.
Thank you, Dr. Sonali. I'm Dr. Supriya Mathur, and I'm a psychiatrist currently working in Jaipur. And I would be sharing my experience as a psychiatrist who was deployed in the COVID area. Next slide, please. Okay. So when we were informed that there's one more slide before it. Yeah, thank you. So before starting with the COVID duty, we were informed that we will be deployed to the COVID wards. And that was a mixed bag of feelings for me. I was anxious, I was jittery. There was a sense of apprehension that what will happen to me, my family, will they be safe or not? And I was feeling a little inadequate, and even my colleagues, that being a psychiatrist, how would we be able to do this? Because we are more or less used to seeing medically stable patients. But then at the same time, being a pressure of being called as a COVID warrior was also setting in. And there was an adrenaline rush as well, that we would be taking care of the patients in COVID ward. So there was this, hence there was a mixed feelings. And also, it had its own implications that people stayed away. Since we were going to the hospital, we were deployed in the COVID ward. So people were just like, "Arey, she goes to the COVID ward. She's a doctor, so let's stay away from her because she might be a COVID patient." Can we have the next slide? Thank you. So when the COVID duty started, firstly, we were well oriented how to don and off the PPE kits, but the moment we wore the PPE kits, we were not used to it. So there was, again, a lot of fogging. We could not see what's lying ahead of us. And we were just like rechecking our PPE kits, whether it's intact or not. And one of the difficulties which we faced is that we had to speak in a louder tone. We had to speak in a loud voice. There were face shields, there were masks. And then due to the double glovings, it was difficult for us to examine the patients because there was a decreased or degree sense of touch. And then let alone we had 6 hours of duty, so there was a lot of thirst, hunger, they were sweating because it's Indian summers. Apart from it, because the patient load was a lot, we were supposed to do a lot of paperwork, and then at the same time constantly seeing patients in misery because they were all alone in the COVID ward suffering. They were angry, and they were having guilt as well. And in few times also we witnessed that patients were so angry that they used to just tell us to stay out of the room, and they would not let us examine or even talk with them. And patients don't recognize us. They used to call us, they used to get scared of us, saying that, you people are in plastics. And then at the same time, at the personal level, we were seeing dying patients or patients who were near death, and that was something which was which we were all shaken up with. And then at the same time, there was a burnout. We were all getting mentally fatigued, and lastly, we had a reduced adrenaline rush. Next slide, please. So after the COVID duty, of course, we had the physical symptoms like fatigue, rashes, dry skins, abrasions, cuts. But then at the same time, we had a sense of guilt that we were not able to save our patients, and there was such a lot of misery around. It was a helpless situation, and since we were in the COVID ward, we had to be away from the family members. There was again, whenever we used to try to sleep, we would constantly hear the sounds of beeps and the ventilators, and that also caused trouble in sleeping as well. Next slide, please. So after the patients had recovered, or when we would talk with the family members who recovered from COVID, I saw a lot of guilt in younger members because they were the earning members of the family, and they had to go out, and eventually when they came back home, they had infected their elderly parents or elderly members of the family. And and many of my colleagues and many of the patients, like a lot of family members got infected, but one person who was taking a lot of precautions did not get infected. So there was a lot of caregiver burnout, a lot of grief was seen, and of course anxiety and depression was also seen. At the same time, I could see in the general population a lot of anger and frustration coming up, and at the same time, patients who had recovered from COVID due to the steroids, they had got psychosis as well, and there was exacerbations of mental illnesses as well. And in the general population itself, there are many patients, or there are many people who come to us saying that they feel very stagnated, they feel empty, and they just feel that they are not motivated enough. A newer term which is called languishing. Next slide, please. So there's the few solutions or the lessons which I had learned, or which we all had learned collectively, which I would be discussing now, is that as a psychiatrist or as a clinician, we need to keep our anxiety at bay, and that can be done by being prepared and being abreast with all the latest updates. And we can also take in help with the experts. We can connect with them and take in knowledge from them. And we also need to accept that these are trying times, these are hard times, and we cannot help or save everyone. But as a psychiatrist in the ward, it is important that, or something which I found important was that I let my patients talk. And with talking, they could ventilate. There was catharsis, and they felt a bit better. And the same thing I had applied it on my colleagues or on the staff as well, which helped them a lot. And as a human, we really know that what helping does to each one of us. We had to help the nursing staff as well because they were overloaded with work, and we try to keep the environment positive. Like, we used to have a small meeting right before starting the COVID duty, and which would motivate them, or which would help them, to take care of the patients in a better manner. And lastly, keeping patients is something which we all require at this point. Next slide, please. So as healthcare workers or as doctors, we all need to fall on each other's back and build energy, because as the latest trend is showing that the mental health pandemic starts now. So we really need to support one another. We really need to talk with one another. We really need to have a good support system, a good network, which plays an important role. Next slide, please. Thank you. And at the hospital level, some suggestions or some studies which have come across is that to ensure preparedness, we need regular and intensive trainings, and they can be hospital-based programs which can be mindfulness-based, so that the anxieties, apprehensions can be kept at bay. And we can also give balanced allocations of duties with off time for relaxation and family time, which may be given virtually, of course, in these times. And there are studies which suggest that spouses reduces stress level by 40%. So these are some of the inputs which I would like to give. Next slide, please. So lastly, something which I've learned, or which my colleagues have learned, and which I would like to tell, is that this pandemic has humbled each one of us down, and it has changed our perspective in all spheres of life, be it personal, professional, or in social life. Thank you.
Thank you so much, Supriya, for sharing your personal journey through working in an acute COVID ward, and also the expertise that you were able to bring to the ward with some really helpful suggestions towards the end on the lessons learned. And as you said, we are probably embarking upon a mental health pandemic, and preparedness is what is going to be helpful to us. So keeping that theme, I would now like to invite Dr. D.V. Singh, who is a consultant and clinical lead in substance misuse, working in the UK, but has also been supporting remotely to clinicians as well as friends and colleagues in India. Dr. D.V. Singh, thank you.
Thank you so much. Good afternoon, good evening, everybody. I'm Dr. Devrit Singh. I'm a consultant psychiatrist, and I have a special interest in substance misuse. So currently, I'm a clinical lead for one of the counties, but that's not why I'm here today. Maybe I am. Next slide, please. We'll come to that. So I'm here to talk about the medium and long-term sequelae of this pandemic, and also about de-escalation techniques. And the reason for that is because I am in touch with a lot of my friends. I also work in India, and I know how things are. I wanted to touch about the de-escalation because the assaults, as you all are aware, the assaults on doctors are on the rise in general, irrespective of COVID. If you look at the incidents of doctors and hospital staff, nurses being assaulted by patients and their relatives, it was almost an everyday occurrence. And during COVID, this has escalated even more. One of the things that a lot of people were reporting to me is that, oh, these people, they don't understand what stress we are under, etc. And then they're hitting us. And so first thing is, everything's not in our hands. There are geographical variations, regional variations in the assaults. I'm not going to go into the details, but some areas, people are considered very short-tempered in some geographies, and then they are more prone to assaulting. But over here, we're only going to talk about what's in our hands, not what, you can't change your geography, probably. But we're going to talk about why this is happening and what this leads to. So we as professionals, as doctors, we are here, we are trained that, we are supposed to give answers, we're supposed to solve the problems, we know we are the experts. And when the patients actually don't see that, or the families don't see that, then the tensions flare up, the emotions flare up, and we know what happens then. Other things that are known causes of assaults on staff are actually commonplace, a way of working in India. So for example, rushed, not being able to give enough time, having a lot of workload, seeing a lot of patients, burning out, working longer hours, etc., etc. I am not proposing European Working Time Directive. in India, because again, that's another thing that's not in our hands. Seeing less patients, again, not practically possible. Next slide, please. Thank you. So what we need to do is get off this thinking that it's us versus them, because someone's dying in a family, you know, emotions, they're very emotional. The family is very emotional over there. I'm the first to admit there's no 100% answer to how to stop the assaults. We can't stop it. We can only maybe minimize it a bit. And first thing is, we need to recognize the danger signs. So for example, if you see, you know, the common danger signs before an assault is pacing, voices being raised, intrusion in personal space. Personal space, as you're aware, varies between cultures and varies between practice. What we consider personal space here will be different to what we consider personal space in, say, India, or even America for that matter, or even Europe. So the danger signs are they'll be coming close to you, the voices will start rising, you know. The role of a doctor is very different in India as compared to, say, Western Europe. So over there, it's very commonly, you know, doctor is God. And then suddenly, when you're from that pedestal, you're assaulted, or you're at least made to believe. I know a lot of you will be thinking, oh, that's not the case anymore. Yes, but when we all trained, you know, that was the thing, oh, doctor is next to God. And then suddenly from that pedestal, when you're punched in the face, like, what's happened? So that's all the more confusing. So de-escalation, there's a lot of training. I'm not going to go into the full details of de-escalation, but one thing is importance of communication, having a sort of private space, not talking to them in the corridor. Then again, being alone also causes, you know, increases the risk of assault. So by private space, personal space, I don't mean being alone, but don't talk to them in in the middle of the ward or corridor in front of everybody, because then the emotions rise. Also, what we need to understand, the body language, tone, they are very important, more important than the words you use. Of course, words hurt, but tone and body language is important. Now with double masking and shields, you have to raise your voice, but that's your volume, not the tone. If people find it helpful, we can look at organizing or, you know, sharing some videos about the techniques in general. I'm just for now touching upon the topics. Also, you know, your body language, your awareness of not intruding in patients or the relatives, families' personal space, having the respect, empathy, and answering honestly. We don't have to have the answers. It's okay to say, I don't know, I'm not sure, but I can find out for you. The practice that we do in India, it's very common that we're supposed to have the answers, and we try to give the answers. That might not be really the best thing. Next slide, please. I just wanted to give a background. Both my Indian colleagues and the colleagues in UK will agree. So just going to the basics, one of the common exam scenarios over here in the West is how to break bad news, how to deal with an angry relative, and how to tell someone that the relative has died. So breaking bad news is that he's on the verge of death, or the prognosis is not very good. And then also there's a station for informing the family that the patient is dead. And that's actually a very important exam station. My colleagues in India will be surprised to hear that that is actually considered more important than actually memorizing the dose. If you actually don't remember the dose, it's okay to say, listen, I'll just look it up in a book and be sure. And maybe my colleagues here in the UK will be surprised that these exam stations, which we take for granted, are actually not given much importance in the training, in the foundation of doctors. So when you actually have to break bad news, there's no techniques, there's no rehearsal done. You just go and tell them, and you're left on your own. So everyone has a different approach. Some approach might be seen as very blunt, and the family might not like it. So my recommendation is very strongly to provide training on these three important key aspects, and that would definitely bring down these escalated emotions, heightened emotions, and maybe reduce the incidence of assault. Next slide, please. Now I've come to the impact on the health workers.
Sorry, Dave, just to, you've got about a minute left.
Yes, so I'll just touch upon the PTSD. We've already heard about the immediate, shock syndrome, etc., and the COVID warrior. So the COVID warriors, the parallel is we are in a war. I've just put some symptoms down. They are not necessarily in line with the importance of ICD or DSM, but these are just something to be aware of, like stress, insomnia, mood, impacts on mood, substance misuse. These are taboo topics. And then I'll just go through very quickly the symptoms of PTSD. So flashback, avoidance, hypervigilance, arousal, irritability. I just want my colleagues to be aware of all of these things, not think of them as taboo. We are doctors, we are humans. We can be touched by all these things like any other human being. You feel like, drinking a lot just to forget all of those things. That's where it can start. And all of these instances, if it's helpful, again, I'm happy to talk about them in details. And today, I just wanted to touch upon these things and these symptoms so that you're aware. Thank you. I'm happy to take any questions.
Thank you for that, Dr. D.V. Singh, and we'll come to the questions towards the end. But as you said, for raising just awareness and highlighting, possibility of post-traumatic stress disorder as well as drugs and alcohol problem within our colleagues and bringing that to the forefront is also important. So thanks so much for that, D.V. Singh. And I would now like to welcome Professor Arun Kandasamy, who is an associate professor from NIMHANS, to give us a view from India. And he's also chairing the task force on Doctors for Doctors. Professor Arun, over to you.
Thanks, Dr. Sonali. Good evening, everybody. See, there's a lot of things in the training itself. It makes us vulnerable as a professional. The healthcare professionals are always vulnerable for mental health issues because we've been asked to be perfect within our profession, and we are always being asked to be correct in the response what we give over there, and we always have an idea that we should correct all the sufferings of people. Now this leads on to a lot of mental health issues, whether it is COVID or not. We always have a lot of mental health issues, and majority of the time both the physician, the clinicians, and other healthcare staff reach out to any kind of help very late. For example, one of the studies which we did on the substance use disorder itself, we found that it takes at least 11 to 12 years. It's in India. It takes around 11 to 12 years for a physician to reach out for help if they have a substance use disorder after development of the substance use itself. And this shows how much is the reluctance, what are the barriers, and what the reluctance and the barriers and the resistance to any kind of interventions per se. It's not that they don't know the problem, but they have the reluctance to bring it. And even if they are willing to let go the reluctance, there are a lot of fear about what's going to be the repercussions if they go for help, and what others get to know about it, the confidentiality issues within the organizations per se, and also about their capability to continue working. All those things comes up, which in general makes the healthcare professionals, especially the doctors, as a vulnerable profession for any kind of mental health issues, from acute care, acute mental health issue to the chronic mental health issues per se. When it comes to the COVID pandemic, what we have realized is a lot of uncertainty, the way in which the social environment, the political environment, the healthcare system, everything is getting into a toss, and we don't know what we are doing and what we have. We have been asked to jump into treatments without much help, and then slowly we are learning about it. This creates a lot of uncertainty in people, and also to face with stresses of failures, multiple failures, and in terms of treatment strategies, and deaths happening day in and day out in a large number, and the distress which is being seen all around takes a big toll on the health professional per se. Not only the person's issues, it's also about the family and the immediate family and the extended family. All of them are in stress. Sometimes the healthcare professional not available to take calls, or being available to extend their own services to the family members, because either they are in quarantine, or they are in isolation, or they are on duty. A lot of things produce a significant amount of distress. And as Dr. Supriya and Dr. Dev had clearly pointed out how much is the problem, and Supriya has illustrated what kind of difficulties which the healthcare professionals go through. And I appreciate Dr. Supriya's effort as an individual in helping the population which she is coming across through her own journey through the path. Now, a lot of individual work is going on from each mental health professional to help their own colleagues. Also, there are organizations creating the websites and hotlines, helplines for help towards healthcare professionals per se. But unfortunately, the reach of all these things, the visibility of all these services available is very less. That's where systems like us, in terms of the organizations like Indian Psychiatric Society, Indian Medical Associations, we have to come in and try to help out, create visibility in terms of the health professionals reaching out to mental health care per se. For that, we have gone through multiple steps of work. One of them is creating a task force called Doctor for Doctors. And this is a very new task force in the Indian Psychiatric Society per se, a year old. And we have created a certain set of, we have just started working on different aspects. Next slide, please. One of the first thing is to coordinate with other agencies which work with doctors and the welfare of the doctors. One biggest organization in the country, in India, is Indian Medical Association. And they do have a task force which looks at the welfare of the doctors inside their own setting. And we are coordinating with them. We have signed an MOU with them, and then we are creating a group of committed people and like-minded people who are willing to take up the tasks on systemic level for creating awareness and making treatment possibilities, availabilities, and then certain systemic changes to bring in, not only during this COVID pandemic period, but also for an extended period of time. Next slide, please. One of the major steps is to create and collate relevant materials in terms of mental health disturbances, the assessment part of it, and treatment aspects, and the treatment aspects involving a lot of self-care modules for one to help themselves. And this making it available for all the organization, all the members of the organizations, like Indian Medical Association, Indian Psychiatric Society, and all the other organizations which work with healthcare professionals per se. Next slide, please. The other task which we have actively taken up right now, and it's going on, is to create a database of mental health professionals, especially psychiatrists who are members of the Indian Psychiatric Society, who are willing to work with doctors who have specific mental health needs, and try to and are willing to give exclusive time for them and exclusive space for them for consultation and treatment. It could be the psychiatrist, it could be the organization, it could be support groups. We are collecting informations all over, and then in next few weeks of time, we would make it available for members of the Indian Medical Association and all the other bodies where it can reach out to doctors, where this information in terms of a database of mental professionals who work on various areas, whether it could be mood disorders, it could be substance use, it could be somatoform disorders, it could be psychotherapy, just counseling, and various other treatment modalities which people can provide, and the helpline services. All these information should be readily available for anyone who would want to utilize it. The level 2 on this, we are right now we are creating this database and also creating certain SOPs about how do we go about delivering this this service, and how to coordinate with the clients and the psychiatrist per se. The second step is to create an app. I had worked with some of the people in UK who had created app for the doctors for consultation for the physicians who wish to have mental health assessment and treatment. Now that's our next step, to create an app which is specific for doctors with mental health needs. Next step. This is something which is very important, we feel, because mental health needs of various doctors need to be addressed at various levels. One of the early thing is there are a lot of doctors who are attached with medical colleges, which has the structure of students, residents, interns, and faculty and other doctors attached with the hospital itself. And many of the system doesn't have any mental health support system per se. We would like to assess this and then provide certain set of guidelines which would be helpful to present to the National Medical Council. And if that regulatory body can push it to the mandatory need for any kind of medical college which needs approval, it would be it's something which we are hoping to achieve within in a year's period of time. Next slide. This is the last one. This is a long-term plan and the dream plan as such, like to create a physician mental health program for the country itself. It's we know that it's a grandiose theme at this point of time, because there is nothing which is available at this point of time. We need to review a lot of things, what systems available elsewhere, what's the statutes and laws of India which might help or hinder creation of such things. And as organizations, IMA and IPS, if they could set it together in next few years' time, if we could create a physician mental program, that's the best thing which can happen to our population. Thank you very much. I would like to receive all suggestions and support from you all.
Thank you so much for that, Professor Arun Kannasamy. That was really heartening to know that that there's a lot of thought process going behind how to build support for our healthcare workers. And I think it'll be helpful if you can put in the chat functionality if people from India and UK do want to make suggestions or support you in this program, how best they can do so, whichever best way that you'd like us to contact you. Now I would like to welcome my colleague, Dr. Harbinder Sandhu, who is a psychologist and is an associate professor at the University of Warwick and consultant health psychologist, and would be talking about well-being and resilience, the proactive work that she has been involved in the UK. Thank you, Harbinder.
Thank you very much, and good afternoon and good evening all. So there's been some excellent presentations so far, and I think what I will do is hopefully pull some of those together, in particular drawing on some of the guidance that we've been using to develop some resources in the UK in terms of well-being and resilience. Next slide, please. So first of all, it's quite important to understand what do we actually mean by resilience, and I think what's quite clear that has come across in the previous presentations is that resilience is a multifactorial process, and therefore it's going to need a variety of different resources to be able to manage all the different impacts that has been sort of clearly described before. And in particular, I just referenced down there, Polak and his colleagues last year published a Cochrane review looking at interventions that have were designed to support resilience and well-being of frontline staff. They identified 16 interventions or 16 studies, and the generalized grouping of those studies were around workplace interventions aimed at education and training, improving communication strategies, and also psychological interventions as well. Next slide, please. So as we go through the presentation, I'll be referring back to that Cochrane review, because they do identify some sort of barriers and facilitators also in being able to actually implement some of the interventions and programs. So the British Psychological Society developed last year some guidance on how we could respond to the current COVID pandemic, and identify 3 main phases. And that's the preparation phase, the action phase, and recovery phase. And it's a transition between these phases, which is also quite important. And quite clearly, we can see right now with the situation in India that, you know, we are in the action phase. So the next couple of slides will really focus on what we've learned from these guidelines and what resources are mapped onto the action phase. Next slide, please. So in the active phase, and again, this has already been highlighted in some of the previous talks, we're looking at impact on a variety of different physical and psychological needs. So this ranges from things like lack of clarity and uncertainty, and, you know, feeling a sense of helplessness and lack of control over the situation, and also neglecting self-care, and that's physical as well as psychological. Working hours, so, you know, working absolutely sort of long hours, sort of out of normal routine, and not being around family or loved ones, and also obviously having sort of fear around not seeing them, your family, and communicating with them. And then just one of the other impacts related to being in the active phase is adapting unhelpful coping strategies, and quite often that could be for a variety of reasons. One of those reasons is not being able to feel or confident enough to feel that they can reach out to either senior management or staff or other colleagues. And again, that's been highlighted as one of the factors that we can have a lot of resources, but ultimately we need to really engage with people so that they feel that they're able to reach out and get the support they need. Next slide, please. So the British Psychological Society developed the guidance in the active phase and produced a stepped care approach. And where we are at the moment, and I think Ananta very nicely summarized this too, is what is crucial is the basic needs. So the physical needs, which is keeping hydrated and having access to food 24/7. Having the space to be able to have rest, sleep if working absolutely, you know, long hours, and just having time to, even if it means sitting in silence or around other colleagues, but having that safe environment where you're able to sit down and just have that bit of a break from everything that's going on. And again, having those environments is good, but it's about how we can engage our staff to actually make use of those environments and feel like it's okay to have that time out, not feel guilty and feel that sense of, well, I should be working. Next slide, please. So the Health Psychology Exchange has brought together health psychologists from around the country, and a subgroup of that is of health psychologists looked at psychological interventions. And Rosanna Brady led some work on developing a tool which is called the Psychological Needs Assessment Tool. And this tool is really designed to help facilitate discussions with those sort of senior management for those that are implementing any sort of health and well-being within their current organizations. Because quite often the first thing we need to do is identify what are the gaps, what are the challenges, what are the barriers, how can we help to facilitate that? So having that conversation, having an open and honest conversation, and being able to sort of come up with solutions together is what this tool is designed to do. This tool has actually been implemented, and a paper has been published with some case studies identifying where it has been successful. Next slide, please. So just in terms of looking at different types of interventions or programs, we can see, and they map quite generally on some of the key areas I've highlighted in this slide. So having that safe space, we've talked about, having time to rest, but also having perhaps a confidential support system. So whether that's the telephone line or whether it's via email or either talking to someone face to face. And in the medical school, we had our medical students that were working in the trust during the first phase of our pandemic. And one of the positive feedbacks we've got from our students was feeling supported by their senior tutors. So we had regular meetings on a weekly basis, and quite often it was just to troubleshoot perhaps, or just have that support available. The other thing to consider now is about wellbeing apps, because we've got resources around wellbeing apps and sort of virtual ways of being connected. And one of the things that could be successful is having a WhatsApp group and buddying up people within an organization. They know each other and they can feel supported and contact each other as and when they need to. Next slide, please. Just a couple more slides. And then finally, it's important to consider, like I said, what are our barriers and facilitators in implementing our resources? So knowledge and awareness. So, really speaking to our senior management to this at organizational level as well as staff level, and normalizing that it's okay to feel the emotional responses that they are feeling and seek out support. Obviously, the equipment available is a massive factor and quite often out of control, but again, it's doing the best we can with what we have and allowing staff to feel that it's okay to have that time out to seek help. Facilitators, so again, looking at what can we adapt in what we have. So even in between rural and working in the city, like I mentioned about wellbeing apps, is it that perhaps communication is better on notice boards or looking at the WhatsApp groups as buddying systems? And creating that positive, safe learning environment. And then just finally, one of the things that has, again, we're getting some positive feedback from is staff feeling valued. So some chief executives across some trusts have recorded videos where they are, showing messages, just thanking staff really for all their hard work that they are putting in. And feeling valued is a really important part of sort of the reflective process. And then finally, as we're moving on, we will be moving into the planning phase, as we go into the recovery. So it's thinking about, and I'm glad it's been mentioned previously, it's thinking about what is the chronic impact of this. It's not sustainable. Staff will need time to reflect in their own time. And then obviously putting into place whatever psychological support they need before returning back to any sort of form of normality. Thank you.
Thank you so much for sharing that, Ravinder. And it's again good to see some of the common themes that that you have been thinking about, such as well-being apps, and something that Arun spoke about as well. I'd now like to welcome Dr. Alison Tavare to lead the question and answer session. Thank you, Alison.
Thanks very much, Sonali. It's been really helpful for me as a GP to actually get so much learning from what's happening, obviously, in the UK, but also what's happening in India. So thank you. I've been asked a number of questions in the chat function, and we may actually run over a few minutes if we answer them all. So we do apologise if that's okay, but we thought that since we've got such a great panel together, that we might try and take the extra 5 minutes if everyone's happy with that. So if I could, thank you, ask the panel now to put their cameras on so I can then see people. So I'll try and pose a question to the right person, and if you've got something else you want to add, please wave your hand. So Anantra, thanks very much, Anantra, for all you were saying. You mentioned safe spaces, and it's also come up with what Harbinder mentioned as well. Could you give us some kind of practical help, practical information, what actually comprises of a safe space, what works?
Yeah, thank you, Alison. That's a good question. And I just want to start off by saying that safe spaces are more about how those spaces are delivered rather than where and by whom. So Firstly, it's important that safe spaces are accessible at a time when it's required. So they need to be responsive and flexible. So different timings and locations or different mediums suit different people. But some of the important characteristics are they need to be confidential, whether it is confidential in a group as part of Chatham House rules or if it is one-to-one. The person needs to feel, needs to be able to trust the person who is listening to them or who is providing them with the support, that what they are saying will be respected and kept confidential, that it will be validated, that they will be believed, that their feelings or whatever they're experiencing will be taken as what they are indeed going through, that there will be no judgment based on expressing those feelings, either in terms of an adverse impact on their ability or making a judgment about their ability to cope with the work and the kind of commitment or clinician competence they show, and both in terms of the impact on their career, for example, in being reported to managers or as part of a performance management. It does need to be a listening space where people are able to either talk or be, whether it is silence or talking or drawing or whatever it is. It needs to be a space where the focus is on the individual or group which is being given a chance to express themselves. And certain degree of it doesn't need to be run by those who are qualified professionals in mental health, but a certain degree of psychological savviness or psychological mindedness, which enables the person who is offering the safe space to listen, empathize, validate, and respond in a way that makes sense and feels authentic and right to the person who is seeking help. So these are some of the characteristics of a safe space. And in our trust, we ran these through the staff wellbeing service, but they can be run at team level. They can be run through online support or teams, or even in a room when it is possible to meet. Thank you.
Thank you very much, Ananta. And Harbinder, I hope that kind of covers most of the points that you raised. Thank you.
Absolutely, yes. Thank you.
Brilliant, thank you. So following on that, Supriya, you mentioned a support network, that you set up a support network in your hospital. Are you able to expand a little bit more about what that support network actually how you did it? Thank you.
Sure, thank you. It started more on a personal level, since I belong to Department of Psychiatry, they were staff and they were people who had come to me for just to talk and to seek sort of guidance, what can be done. So we actually kept a schedule. Then we planned to keep a schedule, like for these many hours you can come and contact us, and then we can provide you all the things, and we can support you, as well as apart from that, we also are now planning to hold up group meetings. So let's see how it goes.
Thank you very much. Okay. And I'm sure other people have got other ideas to share. And we will be sharing resources afterwards of all the different webinars, of the localized supports and apps that may be available for clinicians both in the UK and in India. So thank you. Dave, I'd like to ask you a little bit more about PTSD. We discussed it briefly beforehand, and you were kind of talking about the timing of when PTSD presents, and perhaps raising our awareness of it as something to look out for. Would you mind? Could you share a little bit more about that? Oh, you're still on mute. Sorry.
That's right. Thank you. So PTSD, as we are aware, is not an immediate sequelae. It's seen in the classic picture. It's within 6 months. But as I said, disease doesn't read the book. But definitely over the next 2 or 3 next few months, we're already couple months into this episode of pandemic. So my suspicion is over the next few months, we will start to see these features of arousal, nightmares. I've already anecdotally started seeing them. The shell shock, as Supriya mentioned, has already started. That it's actually a war situation that was reported in the World War in the soldiers, and that we're seeing in the healthcare professionals already. And also, I know anecdotally, substance misuse has started as well, anecdotally. I think my Indian colleagues will agree. So the next logical step and progression is to this medium and long-term sequelae. We're seeing the burnouts already. We're seeing the shell shock, numbness. Our doctors are telling me tears have dried up, no time to give condolences. Emotions are all drained away. And now problems in sleeping have started. I suspect if we tease out how much of that is due to nightmares, how much of that insomnia is due to hyperarousal. Once you're on the it's so difficult to be aware, because when you're working non-stop for hours, how are you even aware of your body? So the common things to look out for over the next few months in my colleagues would be arousal symptoms, inability to sleep, irritability, quick to anger, which again leads to that assaults, de-escalation, ties up with that. Trying to avoid going to those places where you've seen people dying. And will that impact in staff sickness or not being able to work, or presenteeism? As Ananta said, that you're there, but you're working like a zombie and you're not really there. So yeah, all of these, see the symptoms of PTSD, you can look on Google, on any of the books. I'm not going into the importance. The main thing is I want to talk about the awareness and the importance. Anything that you see is not you. Your family will notice it first. They will say something vague like, this is not you. They might not be able to express it well. So I don't want people to tie down with some words of hyperarousal, hypervigilance, looking back, those kind of things. If you feel, don't wait till then. If you feel, or people around you, more importantly, feel that you are just not being you, then talk to somebody, seek help.
Thank you. That's very helpful. And I think also very helpful that we as clinicians have that responsibility to look out for our colleagues, because you're absolutely right. Families may notice, but we will notice when our colleagues are behaving differently.
Yes.
Thank you for that. Now, I know this webinar was on well-being of doctors, but we've actually had a question about how COVID's affecting the mental health of our patients. And Aaron, I did ask whether, although it wasn't what you were talking about, whether you wouldn't mind just briefly giving us an idea of what you're actually seeing.
There are various, like I'll shift my hat from the system perspective to the clinician's perspective as such. Like there are quite a lot of problems which people come with. Like when you look at as a clinician, what we really need to look at is whether they had a mental health problem to start with itself. Like are there mental health vulnerabilities in them to start with? They present with whole host of things, especially the worsening of the symptoms which they have had. One of the problem with this whole period of COVID and the lockdown and the restrictions, the system was not prepared to take care of people who are already under treatment, and many of them went without treatment, because those who are receiving treatments from the state, from the government facilities, and when they are not available to provide that, and the accessibility to the medicines which were given free were not there, it's quite a lot of problem which happened at that point of time. And then because of that, worsening of mental health issues has happened. Second one is the way my dear area is to work with substance use disorders, and alcohol is one of the major problem in our part of the country. If you look at alcohol, because of the restrictions and the lockdown, alcohol was not available. Many of them landed up with significant amount of deliriums and delirium tremens, nutritional issues. Quite a lot of symptoms were resembling COVID also. Whether it is a dilemma for us whether to investigate for COVID over here and then start treatment, because if we wait, these people will throw seizures and they will have a mortality with that, with the delirium itself. It was quite a lot of nightmare at that point of time because of non-availability of alcohol. That's a sudden move. There is a lot of reason why people are brought in, but the patients are suffering on this side. There are other things in terms of one, the person. It is an abnormal stress which a normal person also feels very difficult to handle, and that a lot of things I think Dr. Ananta has put in terms of moral injury. It costs a lot of moral injury to people, because this is not something which they're used to. And one is their own personal distress, also seeing families undergoing distress. People around us are leaving, and we are not able to say goodbye to them also many times. And it is a very, very pathetic situation, resulting in a lot of acute stress reactions, presenting with a lot of somatic complaints. The non-communicable disease for which people were taking treatment, they've stopped those treatments because a lot of emotivation had set in, like, what's the point, right? And then that has resulted in a significant amount of morbidity also, and a lot of avoidance, anxiety issues. And also, to be frank, a lot of mental health issues within the family has started to creep in terms of, because earlier when you were exposed to your spouse or your children for 8 hours or maximum 10 hours, if you're 24/7 over there, that has a result in significant amount of issues, including marital and other issues as such. Like children are supposed to go to schools, meet people socially, have things socially. Unfortunately, nothing is available and everything is online. Now, all the while we were teaching use less gadgets for certain age group of children. Now, how do you say that? And all of them are in the gadgets. Now, it has created another set of problems, and it creates anxiety in the parents. It also creates at a level that children are not able to interact with them normally.
Thank you. Gosh, I mean, it certainly gives a lot to think about, and thank you so much for giving us a broad idea, and particularly the impact of COVID on people who already had mental health problems, but also the emergence of new mental health problems for adults and for children. So that's been a really helpful overview. And so the final question, so we are going to run over a little bit more, is Harbinder, I don't know how fair this is to ask you, but we were asked in the question online, is how many people are actually affected with mental health problems, both medical and actually amongst our patients? Is that kind of data available yet? Or we all think there's quite a lot of problems, but are we right?
Yeah, I mean, it's a good question. I think the data is emerging, and I think there is, not everyone will go on, obviously, to have the sort of PTSD, but there's a high risk of that. And I think what we want to do by putting in place like programs like this is to prevent further complications or further severity of mental health developing. So the more we can put in now, the better we will be at helping, I guess, before reaching the point of doing that. Now, also, I would say that those that, and I think I mentioned this before, it's probably not answering the question directly, but those that really need it are the ones that probably don't seek out the support. And I think we have to be quite wary of that as well, because, like I said, having these resources is great, but it's really tapping into those that need it.
Thank you very much. And perhaps, as you say, we will be getting the numbers coming through. At the moment, it's just an impression. So I'm afraid there are lots more questions, but I'm afraid we can't answer them all today. But hopefully that's given a broad kind of selection of answers. And I'll now pass back over to Sonali. Thank you.
Thank you so much for those questions and answers, Alison. Really covered a breadth of topics even there, and actually left me thinking that I think we didn't talk so much about the impact on children, and maybe something for us to just reflect back as to whether we would like to hold another session on that and bring in the expertise, certainly, as it would be useful to hear. So thanks to all of you for joining. Sorry that we overran by about 8 to 10 minutes. The session, as always, will be available on the South Asian Health Foundation website, and you will also be able to see it on YouTube. Please do share it with your colleagues. We do have our next session, which is on Thursday, the 20th of May, which will specifically be covering management of long COVID. And there has been some exciting development in terms of the impact of the vaccine as well in people who have had long COVID. We've certainly seen that the mRNA vaccine has shown positive results with people who have had long COVID and in terms of reduction of symptoms. So please do share the webinar, which will be held on Thursday at the same time and will be chaired by Dr. Sarah Ali. The certificates, as always, will be sent out to the attendees. And if you have any other suggestions, please do get in touch with us. There are a lot of resources, or there are a lot of support groups that are being set up by either, as Ananta mentioned, which is the British Indian Psychiatric Association, also by BAPIO, and Professor Arun has also shared a few resources with us with regards to the support groups, the safe spaces that are available. And what we will do is we will collate that and have that information available on the South Asian Health Foundation website, so that you are able to tap into that and also pass that information to your colleagues. It's about preparedness, it's about reaching out. And one of the phrases we use here is that it's okay to not be okay. You've all come through. We are still going through a huge pandemic crisis, and though the whole burden of being a COVID warrior in itself carry its emotional and mental health burden, but there is help available around for you. So please do reach out. Thanks so much. Have a good evening, and we hope to see you again soon next time.